That's lovely. Thanks everybody for joining us today. It's just a little bit past 3, so I think we will make a start. So lovely. So my name is Adam Knight-McKeggie. I am from MER Research, and I'm also joined by Angela. Do you want to say hello, Angela?
Hi, my name is Angela Aiken. I'm Senior Commissioner Manager for Public Health for Walsall.
Lovely, and welcome along to everybody today. So this is the first of a series of webinars that we're running at MER Research on evaluation, different evaluation methods. So today we're going to be starting with one using a case study local to us. We're based in Birmingham, from Walsall Council, where Angela's from. But focusing very much in terms of the evaluation, the kind of methodology on a social return on investment. So this is a project that was done, an evaluation a few years ago now, but actually it's great to kind of share about it now and also look at some of the longer term impact, the longer term kind of benefits really, both from the evaluation, but from the project itself and the evidence that was developed from the evaluation. So Angela will start today just in a little bit kind of setting the scene, and also just setting out what the project is about. I will kind of explain more about the approach that we used and also some of the kind of key findings, and then Angela will kind of finish off kind of topping and tailing, really looking at some of that longer term impact and some of those kind of key kind of lasting conclusions about it. So the whole session is booked in for an hour. So we're not going to be talking for all of that time. Actually, we've got a few kind of videos to show you as we go through. If you do have any questions, we'll be taking kind of questions at the end. So feel free to either hold them till then or to put them into the chat. And one of my colleagues, Rita, will be kind of overseeing that, but we'll be holding up the questions to the end. So lovely. Thanks everybody for kind of coming along. We will keep people on mute just while we go on to kind of save any background sound. I'm sure my youngest daughter coming back from school probably make a sound in the background as soon as I start talking. I probably can't avoid that, but we'll try to do that. So let me first of all, we'll start with this video.
Loneliness. It is a killer. There's no doubt about it. It's a killer. When I lost Doreen after 63 years of marriage, I don't know, it's like a curtain come down. I thought, well, what am I going to do with myself now? I never said goodbye to it. And prior to that, we'd lost Lynn. You think to yourself, well, what else can happen to me? I can talk about it now. When they say, where is it peace now? That don't excuse the fact that she's not there with you. How can you not miss somebody that's been there every day of your life, 63 years? And that loneliness, it is a killer. There's no doubt about it. It's a killer to people. And I've experienced this, and it will overtake you if you let it. Clock watching all the while. You shut the door, you close the curtains to the wind, and then you're thinking, you're wishing your life away. I wish it was tomorrow. I wish it was next week. Then I've thought about it. I wonder how many people out there that are in exactly the same boat as I am. And I felt upset with myself to the fact that I can get up and walk about. Why am I feeling like this? Hello, Kath?
Oh, hello, Ron.
Oh, you all right?
Yes, not too bad.
Oh, God, you sound a bit better. Is everything okay? I've got 16 people now, 10 o'clock in the morning. I can phone Reg. 2 o'clock on the afternoon, I can phone Brian at the Old. I never thought that I would do this, never in a million years, but I'm thankful I've done it now. And you can talk forever, and you've just met him. You know, and then they look around and they say, blooming hell, that time's gone quick. We're not strangers now, we're all friends. You know, oh, it's Ron, it's all right, no, it's Ron, my mate. When you get on the phone, you know, you think to yourself, well, that's okay, it is a wonderful feeling, and no doubt about it. I hope it lasts a lot longer.
That's lovely. So that's Ron. I shall pass over to kind of Angela, really, to kind of introduce a bit more.
Thank you, Adam. So Ron is one of our heroes. He's one of the many people that have been supporting through Making Connections Walsall. He was supported himself and then went on to support other people. The way in which Making Connections Walsall works, it looks at the social demographic, it looks at what the needs are for the individual. Quite often we look at healthcare as a priority, but we know there's a wider need. And if we look at the social economics, the physical environment and health, we know we can make a massive difference. So it's really key for us to consider those different parts. So when we think about loneliness then, what actually happens? Why did we get to the point where we started to look at loneliness? Well, it started off with a Freedom of Information request, and that Freedom of Information request came in to ask what we were doing. So from a public health point of view, we started to look at what the data says, what are the priorities, and we eventually had prioritised for Walsall loneliness. And when we started to look at the different things, how people were impacted by friends being lost, their roles, their connections, the person themselves, and quite often people found themselves on their own, their children were further afield, possibly not wanting to tell the children how they were feeling. This service, we secured the funds to develop this service. But within a public health point of view, we also know that to develop an intervention, it needs to be evidence-based. And we wanted to create a framework that would make the difference. If you go to the next slide, please, Adam. Yes, continue. If you continue clicking, next part of the slide. Okay, wonderful. And from a public health point of view, we know the impact. We could see people accessing services for, GPs, just because they were lonely when actually there were services in the community, but they didn't know where to go or how to access those services. There were different aspects of it. So there was a commissioning process and an engagement process, and it meant that we brought a number of partners together to address loneliness and isolation. And that included the fire service, community organisations at different levels. And they were all funded to a point where they became a whole system. So it has worked really well, but as you go along, you'll hear how it's functioned. Go to the next slide, please. Okay, so initially the programme was aimed at older people, and the aim was to prevent people accessing services preventably. We also wanted to ensure that those who are accessing GPs at crisis point were able to be supported before they got to that place. We wanted to ensure that anybody could refer into the service, and they could refer in at any time. So it could be 24 hours, and having the fire service there, who also offered self and well visits as the independent point, was the important point. If you go to the next slide, please. Okay, so as I said before, there are different parts of it. Walsall Council commissioned a service. The Central Referral Centre was the fire service. They offered self and well visits. There were 4 organisations across Walsall. Those organisations were voluntary sector organisations, and then there were community projects as well. Those community projects offered things such as befriending, knit and natter, bereavement support, dementia cafes, whatever those projects were, walking groups were funded, and it was the community that determined what that would look like. Next slide, please. Okay, so the safe and well visit was part of it, but keeping people well from the 5 ways to using 5 ways to wellbeing was really important. So we used the 5 ways to wellbeing approach, which meant we wanted to look at how we connected people. What did people want to do? We wanted to ensure that people were active. How could they be active? What were the barriers to being active? People were in the house, they weren't having the opportunity to take notice. We wanted them to connect, see what was out there, see other people. We also felt that people felt as they got older, they couldn't keep learning, they didn't recognise the benefits of new things, or they didn't have the opportunities. So we wanted to make sure that they had those opportunities. And as you see in Ron's case, we wanted to give people the opportunity to give, to connect, all these various things for the 5 ways to wellbeing. So we created a evaluation tool to measure that in the form of a wellbeing plan. We used the data collection system, DCRS, to put all the population information onto the system. So each person that was supported would use the data collection system, would use WHO5, the jungle loneliness scales, and you'll see all the various measures as Adam goes through his presentation. It was developed in partnership with the voluntary sector organisations, with the fire service, and with those individuals. So you can see there's a whole raft of organisations that have been part of this programme, and evaluation was the first step, was part of the first stage. Quite often we look to evaluation down the line after we've got a programme in place, but to be effective, the evaluation needs to start at the point of development. So you build in development mechanisms, you build in consideration for, okay, what are we trying to measure? What are we trying to get out of it? How frequently will we be consulting people? What will be feasible? And to do that, we had Mel around the table, we had DCRS around the table, we had the organisations that were going to be delivering the intervention, and it was also myself in terms of who was managing the programmes. And other partners were involved to try and shape it and make sure it was meaningful. Next slide, please. Okay, over to you. Thank you, Adam.
That's great, lovely. Thanks very much, Angela. So in terms of our approach then, so it was a social return on investment approach, and some of you may well kind of know that, have used it yourself. You may have actually been, doing the SROI work. But just to put it into kind of context, really, I think for me, it moves on from an evaluation which is very much focused on monitoring objectives. A lot of the evaluations we see, project and program evaluations, you may have aims that are set up. You may have kind of aims that you've got your sort of funding for, from say the lottery or Heritage Fund, lots of other places, public health, for example, in this one. So there may be objectives, there may be outcomes that are, a change that happens because of those objectives and that activity. And were those intended outcomes achieved or not? Sometimes we see evaluations like that, which is really very much about objectives, focusing on objectives. But you can go further. You can go one step further that really builds on that and looks not just at those intended outcomes, but also unintended ones, unintended changes. Sometimes they're positive, great. Sometimes they're negative. So, it's trying to kind of balance that a little bit, but it's wider than just looking at the intended outcomes. And you can describe this type of evaluation as a social impact evaluation. You can go one step further, in fact, and then look at a social value evaluation, which is much more about creating a frame for deciding how important, what are the important outcomes, and giving you that framework really to show the quantity, the duration, the value, of course, social value, social return on investment, and also elements to do with causality. What was down to the activity and what may have happened anyway, what might have been displaced, what else is kind of going on. So really that framework to monitor that in the round. So a fuller evaluation, we would say. So when people think about SROI, social return on investment, I think people often think about and often have a figure, that ratio in their head. £1 invested here creates X pound of social return on that investment. Yes, that's one part of it, and I'll show you what that is for Making Connections Walsall. But it's more than that. It is much more than that. It's a principles-based approach to evaluation. So, the key one is about involving stakeholders. It's about focusing on what's important and focusing on the changes that are most important to people. About being transparent, about verifying, validating your work. So actually, we probably carry out a lot of those principles in a lot of the evaluations we do, for sure, and probably the evaluations you have done or you seek to do. But it very much focuses on the outcomes and what those outcomes are for the people involved. To be like, beauty is in the eye of the beholder, outcomes is in the eye of the stakeholder. Excuse my puns. But it really is about focusing on those individuals. And for this evaluation, we focus very much on those clients, people like Ron and others that were supported through Making Connections Walsall. Ultimately, though, it should be about creating more social good, about delivering better results. And what was nice about an evaluation that went over a number of years is actually seeing some of the suggestions, some of the evidence we found within the evaluation earlier on, then kind of come into the programme. So more evidence about the need for befriending, for example, and we saw that come on. Actually quantifying some of the outcomes, the change in people from the start to reviews and leaving the project. Actually, that creates some good evidence for the hubs and for others to work with, something they don't always have. So in terms of how we went about it then, so our evaluation approach, so involving stakeholders, clearly that's a big part of it. So we did that by having a stakeholder workshop early on. Angela spoke about that and how that was used to help frame the evaluation. So right from the early days, involving stakeholders and telling them about SROI and what we were hoping to achieve through it. A lot of client interviews, at a time we were able to do it face-to-face. I haven't done a face-to-face interview for a long time. It'd be great to get back to some of that. A lot of fieldwork done in 2019, actually. So stakeholder interviews as well. So those that were running the hubs, the fire service that were doing the central referral points, but also a lot of the community organisations and the groups that were either funded or delivering services to these people and often to the wider community. We also had kind of quarterly online surveys of those 4 locally based hubs around Walsall, just to get that kind of picture of how things are changing as we went through the evaluation. Personally, what I really like about SROI is it fuses together, it brings together qualitative approaches and data and quantitative approaches and data. So you've got statistics, you've got kind of values in there, but actually it's also based on hearing from people, speaking to people, really seeing what has changed through their eyes. So for me, it's a nice approach that combines the two. So Angela said a little bit about the client and the outcome data. So it was great to get that, and actually 5 ways to wellbeing, was one of the measures, and I'll show you a few in a little bit, some of the difference made over the course of the program itself. Asking clients about the changes, what changes for them, and then trying to kind of group them together and look at a chain of events. What starts it, and then what may follow that up. And Ron is an example of that, if you like. Looking at suffering from bereavement, and then what happened first in terms of connecting with others, speaking to others, really lifting him up, getting to the stage where he's wanting to help others, and then gone back as a befriender. So great example. I did speak to Ron as part of our evaluation, and then quantifying those differences and seeking again clients' involvement in quantifying those. What was most important to them? How they rate one over another? And validating our findings, validating results, verifying results is another key principle in SROI. And it was great actually in Walsall Council to come and bring the social connectors together from the 4 different hubs and just to kind of relay some of our findings. Did they chime with them? Does it make sense? And then using that really just to tweak the work that we did at the end. So again, really validating our findings. So I'll just move on then to look at some of the difference made. I had a question earlier. We'll be sharing these slides. We'll be sharing these slides afterwards. And actually, there's a summary version of the report that is also available, so you can see, a fuller version of these results, the approach, and the conclusions, recommendations in there as well. I think what's great is, just looking at some of the kind of visuals and the real kind of diversity of people, the diversity of activities, whether that's dominoes, bottom right, whether that's kind of artwork done at the top, outings, or other activities. I think one at the top there towards the right-hand side is about kind of engaging online. Other activities just about in the middle, you can see a men's shed. So Aldridge Men's Shed. So actually activities for men and for women. But a really lovely spread there. So just in numbers, outputs, if you like, in kind of SROI talk, and we know about outcomes and outputs. So outputs is very much about quantifying the activity that has been done. So we looked up to the end of August 2019, and at that point there were 800 referrals, so a large number, mostly women and mostly people in their 80s. There were some men, some a little bit younger, but that was the biggest, the core age. The pie chart on the right hand side, you can just see where those referrals came from, and actually the NHS sources, GP surgeries, some hospital services directly as well, other community health services referring in to Making Connections Walsall, other statutory services, so maybe mental health services, for example, some kind of physical re-enablement services, the voluntary sector, some self-referrals, and a few we didn't know, the data wasn't there. I think what you see when you kind of start looking at the data and speaking to people is the central role, if you like, that's the importance of bereavement. Bereavement was there for a lot of people. Often a partner, sometimes younger family members as well, children, sometimes multiple bereavements, which compounded the loss, the anguish. But physical and mental health problems too. So I remember speaking to a man who had a stroke in his 50s. He described his world turning upside down overnight. So his world changed overnight. He woke up having had a stroke, had to kind of re-enable himself physically, had to kind of, he ended his work because of that. His mental health suffered, his family relationships suffered as well. So it's sometimes a number of factors, definitely that link between the physical and mental health. There were over 6,000 contacts made by the hubs. So you can see actually how many are made for each of the referrals. Sometimes, often repeatedly, in order to get hold of people to re-engage with them. And for one group, actually trying quite hard to engage with them. Almost 3,000 sessions were funded, were run by funded organisations. So we saw that spread of organisations across Walsall earlier. So, a large number there. And at that point, August 2019, 24 people have been referred into volunteering. I suspect actually that number is higher. A lot of the befrienders, people, befriending telephone calls or contacting people, actually at home, a lot of those had been through this service previously. What we did notice as well is that we kind of grouped the clients into 4 different groups, typologies, if you like. There's a lifeline group, those where physical health and disability was often quite common. Mental health, again, was often quite common. It's, as the man there in his 80s said, it's not nice being stuck in bed. Transport was often quite a barrier, a limitation. So actually the importance of befriending somebody, either coming to the home or speaking to them by phone was important there. But actually a big proportion, almost 60% of the clients that we saw. And for them, it was really around building confidence and gaining some more independence. The next biggest, about 2 in 10, was what we're calling a social add-on group. So again, bereavement's there, usually more independent, definitely than the lifeline ones, able to travel. They may have their own car still. For them, it's about having other activities to do, things to do, as one woman called, spoke to me. But they've already got activities they have going on. And usually when they were signed off for positive reasons. You then have a catalyst group, and that might be people like Ron, who again, bereavement's common, previously been quite sociable, maybe through work, in their family lives. Generally quite a positive mindset, but had been knocked back. So bereavement was a common reason to be knocked back. But then very likely to achieve their goals. They just need something, a catalyst to get them going. So Making Connections Walsall is that catalyst to encourage them to go on and carry on with their life, have a purpose in their life, and becoming a befriender is a really good purpose and actually supporting others. I guess the group that Hubs and others found hardest to engage with, we recorded entrenched lonely. So people where there's a lot of activity, a lot of contacts, attempted contacts by phone, sometimes in person, to engage with them, to get them to talk, to trust a service. Some successful, some, actually this was the hardest group really to engage. And for lots of them, there was existing mental health problems. Potentially, you could argue, then particularly from an independent evaluations point of view, that this service may not be the best, the right service for these people. And actually they may need some more intensive, some kind of stronger, if you like, mental health support to support them and take them to another level, when then something like Making Connections Walsall may be a suitable service. But also that entrenched loneliness, a woman there saying, I'm not bothered about being on my own. She'd actually got quite institutionalized living by herself, as I think lots of older people have done. So just looking at some of the evidence then that we saw from some of the data that Angela spoke about. So this is from De Jong 6, so a measure of loneliness. And really what's good is that the numbers and the size of the bars on the left-hand side, those in green, are bigger. There's more of them. There are again more clients who are less lonely after the intervention than after it. So there were measures taken at different points. So right at the beginning, and then at different review points, and ideally at the end of the service. It wasn't always as neat as that. Real world research isn't like a lab. You do have to work with the data you have, but actually you can see it is stronger there. You do see some people where actually there's no change in loneliness. So that grey bar in the middle, actually that's quite a tall bar, but it's, there are some people, and I think for lots of these measures, where they felt just as lonely afterwards as they did before. They may have improved in other measures though, and some actually feeling more lonely. So you can see some of that there. 5 ways to well-being, as we said, it was another one. And again, here you can see, bigger green kind of bars going up than the kind of red ones going down. Again, some kind of grey ones where it's the kind of same, feeling the same at the different points, the cut-off point. Of these 5, that being connected was the strongest one there. 41% of the clients of the data that we saw were saying actually they feeling more connected. After that, it's being keeping active, and some of these activities were kind of physical activities, going out even, having a day out. So that's kind of going out, going about, not just staying in your own home, and then taking notice with some other ones as well. Depression, and we looked at depression with PHQ-2, another kind of validated measure. And again, you can see there are many more kind of green bars. So people feeling less depressed after the intervention than before that. Some no change, and a few feeling more depressed. So people's depression does kind of fluctuate. But what is positive is there's many more on the left-hand side in green. So those were some of the, if you like, the statistics, but looking at changes over time, so that longitudinal change. These are some of the kind of grouped, the themed outcomes that clients spoke about. And you can see what proportion of clients this related to. So that improved social ability was a key one. So, someone's saying, I'm alone, but I'm not lonely. So they might live alone, but actually they're engaging with others. They have friends. The next one, top right, keeping occupied. And a Lifeline client said, the less you do, the less you can do. So actually keeping stimulated, keeping occupied, engaging with others helps you to keep physically and mentally active. Bottom left, improving mental health. People did speak about, depression, about anxiety, about being fearful of leaving home. And I remember, a woman talking about putting the wall paint on, putting the wall paint on, putting the makeup on before going out to activities, putting her best foot forward. Actually, it is helping to, not just put a face on, but to do that and to get you out and to get you engaging with others. For some, it's about having a purpose. And some of these you can see kind of almost crossover to the 5 ways to wellbeing, in fact. But somebody talking about having a second lease of life, great, really having that purpose, something to wake up for in the morning. And for some, though not a big group, it was about improved physical health. So, some did speak about sleeping better, eating better. Bear in mind, most of the clients were in their 80s. That's the biggest group. So, we're not talking about starting 5-a-side football, starting rock climbing, but actually just getting up out of the seats, out of an armchair, getting out of the house to walk down the road to the shops. Even that is an improvement, and an improvement for some. So I said SROI isn't just about the kind of ratio, about the numbers, but that is a part of it. And our kind of study, our evaluation showed that there was £492,000 invested into making Connections Walsall. Not just direct investment. I think this is one part of SROI which is important. It tries to assign a value for volunteer time, and it generally uses, the value, either the national minimum wage, or the value if you were paying for that service, paying an employee for that service, how much would you pay in order to get that service? So it's giving a notional value so that you're not overclaiming. I think that's important to do. With that, looking at just clients, we did focus home down to the SROI calculations, particularly on clients, those that were supported by the service. But you can see that £1.65 million of value is created by the service. So that turns out to a ratio of every £1 invested directly and indirectly. That's the notional value there for volunteer time, creates £3.35 in social value. So that's that kind of ratio, but it's, what else is happening and what else is affecting the service. So some barriers we noticed. Client engagement, I've already said about that. Geography, geography is important. A lot of the people are kind of quite locally focused, locally minded in Walsall, and want services on their doorstep. That's not always possible. There's not necessarily enough demand in your locality to have that. Transport was an issue, and we did hear of problems to do with kind of ringing ride service, public transport not always going to the routes that people wanted. Also, that it's not a quick fix, both to physical, but particularly to kind of mental health. And sometimes we kind of questioned whether the referrals were the right referrals or whether it was seen as a bit of a quick fix. Home can actually sometimes institutionalize you. You can get used there, you can get entrenched, lonely there. And there was also some mobility issues around home, even getting out of home, literally stepping out of the threshold of home. Some wider issues as well, wider barriers. I said early on that social impact study can look at expected and unexpected changes, and it should. SROI should, social value evaluation should as well. And some clear positives there. So clients volunteering, that was great. I don't think that was anticipated to begin with. Extra activities, not just for the clients, but actually for the local community. So they were opened up to others. So that actually provided more resource, more services, more activities going on locally. So the fire service ran the central referral hub, and as part of that, they carried out kind of countless safe and well visits. And actually that was protecting people's fire, safety from fire in their homes as well. So that was a real kind of added benefit there, not something we kind of quantified, but could be quantifiable. You could have a value put to that as well. Some referrals to statutory services. So, definitely some good work there connecting to other services and signposting and more formal referrals. One of the hubs just said they're making the whole environment more older people friendly. So actually, again, that's a longer term impact, which is great to see. Whereas others said, as well as getting some pot of money from Walsall Council, they were able to bring in either volunteers or resources from other funds and other pots to deliver more services to the people of Walsall. So again, a kind of an add-on benefit there. Some negatives on the flip side, some kind of unexpected negative changes. It was hard to engage some people. And I think that's, for anybody doing this type of work, social prescribing work, it can be hard. It can take a lot of kind of contact to engage with somebody to build up that trust in the first place. For others, we kind of wondered whether there may be a dependence on the social connectors. What would happen if a social connector went away, stopped that service? What would happen to the person they were supporting? And would that then lead to a kind of a more of a negative for them? And I guess just the sheer demand on services. I think, from the 800 we looked at, that's probably, just under 1 in 100 of the older people that could be eligible within Walsall. So, really important service for those there, but a lot of other demand too.
It's just massive.
Can I move over back to Angela, just to look at some of the kind of longer term impact as well?
So what we have having the data and having the evidence was absolutely imperative for us. As you can appreciate, in a time of austerity, you can see that services aren't just going to continue to be provided without the evidence. Well, we got to a place last year where it was looking like the service was going to have to end regardless of the impact. However, as COVID came in play and we became aware of COVID, I said to one of my colleagues, actually, we need to find a way of keeping this service. And the council recognised the need, they saw the evidence and took it forward. The impact has been phenomenal. Thousands and thousands of people have been supported. It became the COVID response service. Now, when you've got a framework in place that you have built it from grassroots and you can see the impact, you could try to bolt things onto it, but the likelihood of it is it's going to fail unless you have the foundations right. And the foundations meant having that initial work developed, working with the partners, working with those organisations to understand the importance of collecting the data. And one of the challenges was initially, well, we're spending all this time collecting data. What's the point? We're supposed to be seeing people, but it proved invaluable. And the impact has been, you can see it in the newspaper articles there, as I said, thousands of people between August and March this year, 20,000 residents that were clinically vulnerable with support. We had so many people supported out of that. 9,611 people were supported, those who shielding. We had 11,550 people had befriending calls. There were 518 food parcels and over 1,000 activity packs sent out for families. So if you think about it, this service initially was supporting 800 people. And those 800 people was really about those different processes, an initial assessment, a follow-up assessment, another follow-up assessment, and then you support them also to other interventions. But this framework was robust enough to meet thousands and thousands of people's needs in a time of crisis. Next slide, please, Adam. Okay, if you'd like to hear from the Walsall Black Sisters, this is one of the voluntary organisations who have been supporting the COVID response. Adam, we're not able to hear it.
Sorry, we may have to. Sorry about that.
Is it not playing? Okay. Okay. So if we go back, so in the initial service, which provided 800 support packages to older people, was fantastic. We had such good feedback. People benefiting from so much work that had been done. However, that was only the start of it, really. When you think about the work that had been done and its capacity and capability, within 2 to 3 days, it became this service that meant so much to people. That was the lifeline. And what I would really urge people to do when you're developing any intervention, any project, any service, to think about what is the outcome and start to think about, well, how are we going to collect the evidence to make it work firstly, but also how are we going to collect the evidence to prove that it worked or that it didn't work. And what it meant was the things that didn't work, we were able to adjust. So we learned as we went along, and it meant that the service became more robust and more malleable and more able to create something new quickly, because you can't create a service within 2 days when you're in the middle of a crisis. It really did require it to have the foundations ready there to do. Next slide. Over to you, Adam. Thank you.
That's great. Thanks for that. Sorry about the video. I can hear it, but you guys can't. It's a shame. So really, just to kind of wrap up with some of the conclusions from the evaluation itself, particularly the kind of early part of the evaluation, you can see there was definitely some kind of longer term value, longer term impact made by making Connections Walsall, by that model, by that framework. You know, even over the time that we looked at it to August 2019, it supported kind of 800 people. It was a really valued service. Was addressing loneliness, was addressing social isolation. That was kind of some of the program objectives. So what it hoped to do, and you know, yes, it was addressing those. What it also did, I think, for those working in the voluntary sector, working with the voluntary sector, it created lasting partnerships. So definitely the 4 hubs that were working across Walsall, they came together, they shared their experience and their knowledge, what was working for one to help another. There's, for a few times, they would pass kind of clients from one to another as well, you know, to better fit maybe a service that was in one area but not another. And also that connectivity from the organisation, the hubs, to their local areas, to their local communities and to the local services that were there. And sometimes, you know, it might just be kind of a church group that was kind of going on, or a luncheon club, something that wasn't always known about. For us, I think from an evaluation point of view, we saw that best value, the most value was created for that lifeline group. So that was about 6 in 10 of the clients, and probably for the catalyst clients. We'd probably kind of question whether the social add-on, what was this the right, you know, there's probably a lot of dead weight. Would this have happened anyway? Probably, yeah. And for those entrenched, lonely people, actually probably a more intensive service was needed, at least at that point. It's hard, though, to assess that at the referral. So, you know, kind of suggestions there. Definitely some barriers, and I think for us it's about transport being a key kind of barrier there, but also what are those existing conditions and being aware of those and working with those. But, you know, as Angela said, you know, some real kind of long-term value kind of created over, not just during the program that we evaluated, but beyond that as well. So kind of our contact details there, and I think we're supported by others, both at MER Research, but also in Walsall councils. And there you can see the 4 hubs, so Age Accord, Bloxwich Community Partnership, Manor Farm Community Association, and Old Hall People's Partnership, that are also still delivering a lot of those services there. So that's the end of our slides. So I will stop sharing it at this point, and then we can open it up for kind of questions at all that people might have. And I don't know if there are any, I'm not sure if there are any in the chat at all. So feel free to kind of raise a hand, put yourself off mute, and ask a question of Angela or I. Have we got any questions? You may be on mute, so feel free to kind of put into the chat. Katie, I think you got your hand up.
Yes. Hi. Sorry, I came late to the party, so to speak. But I just had a question about one of the measures that you mentioned. Was it the John 6? Did I hear that correctly? It was when you were talking about the key outcomes, the loneliness, and you said it was a measure of loneliness. Yeah,
the John 6, so DEJONG 6, so 6-item validated measure. Yeah.
Okay, thank you.
That's fine. And I guess kind of one for Angela as well, kind of setting up the measures to look at for those and the other ones. I think it was important for you, wasn't it, to have validated measures? So
yes, it was absolutely. When you are working with funds that are not recurrent and you know that you have to improve your impact, it's really important that you get validation. So you can create whatever you choose to create, but people will ask, is this validated? And we were able to say, yes, for 3 of them, they were validated. The only one that wasn't validated was the WHOFAC, the wellbeing one, 5 ways to wellbeing one. But that was a process of engagement. So in terms of helping that individual to work out what they wanted to do for themselves, that's what we used to do that. But the validation was the other tools, and it was very, very important to use those.
Yeah. That's great. We will be sharing the presentation as well with people afterwards, so you can see that. We've had a question from Julian just asking, how did you put a price, kind of monetary price, onto the value you found? And that's a really good question. As a key part of the social return on investment, it is about, where possible, putting a kind of monetary value on it. What we did is we used something called the Social Value Bank, that has a whole number of, again, kind of validated measures, the validated values for different activities. So whether that's kind of engaging with services, like for some it may be kind of getting to work for that type of service, community activities, there are some environmental measures in there. So as a kind of a validated one, we use that as a kind of an anchor measure. And then we saw, if somebody said that was worth, this outcome was worth 5, and someone else had an outcome average at 10, we'll then double that anchor value to create different ones. So that's broadly how it's done. There are different ways of doing it, and there's lots of debate and discussions about how to value it. And I think that's just one part of the, an SROI. It should also be about improving social value, and I think the evidence that it's given kind of Angela and her colleagues at Walsall Council has helped to secure the service, in fact, and help it go on further. So we have another question here from Sunny. Are West Midlands Fire Service still providing a central referral hub for making connections?
Yes, yes, they are. So the whole system is still working, but the priority really is the COVID response at this point in time and befriending.
Just a quick one. I see, Elizabeth, you got your hand, but just a quick one from Francis. The Social Value Bank, yes, it is the hacked one there. Yeah. Elizabeth.
Hi. Thanks for the presentation. It's really interesting. This is a question for you both, though I guess you might approach it in different ways potentially. So just, Angela, you mentioned austerity and sort of working in an era where our budgets are sort of limited, and I wondered how you've experienced, or whether you've experienced kind of talking to, let's say, directors or senior council staff, and how these kind of figures that you've been giving, that you referred to, the kind of I can't remember what the figure is, but how much money was saved for every pound spent in, how those sort of landed with senior members of staff, whether they were sort of convinced and they saw the kind of monetary side of that, whether they're interested in the kind of broader set of outcomes that the work showed, and how I'm just sort of curious as to how this sort of approach tends to sit with senior managers in councils in the current era of sort of austerity, and now the COVID, sort of post-COVID era, where I think we'll be seeing many of the same sort of restrictions financially.
Okay, so if I rewind to the beginning, we were fortunate to get $500,000 to start with during a time of austerity. So the evidence was massive in the first place, looking at, we provide stop smoking services, but yet still loneliness is as much as 15 cigarettes, can be as much as 15 cigarettes of the equivalent of. So that evidence, I think people, there is something about the academic and the data, but there's also something about the heart. So when I started to look at the issues around loneliness and we looked at the local communities, it was really, look, people are isolated and lonely. And we looked at our own individual families, and that was the argument that was presented. Then over time, it wasn't immediately, but it took me a while to get the funds in, and that was out of reserves. So there was obviously a conversation that worked somehow, but I think it was really hard. So obviously we've got the minds there, but sometimes we do have to get the hearts involved. And it secured it at that point. I suppose as we continued to go forward and things was getting tight, it was something that was looked on to be removed. And the evaluation report was ready the January, February, I think it was, and we had an event in February. I can't say that I did anything amazing for us to then get extra funds because COVID hit, and it was a COVID that made it be extended. I suppose it has been so important to the council, and so many things that have happened. My colleagues who have been working on it have continued to prove that it's invaluable, and many, many vulnerable people would have really struggled much more than they did if it hadn't been in place. So the council has really backed it. The councillors have backed it, and it is a key part of the work that's done. I'm not sure what the plans are for it going forward, but I do know it has been very, very much valued, and the evidence has has been invaluable. Also, the data collection system, the way in which we use that as well, was therefore, they was able to use it to prove that these are the amount of people we're seeing. They didn't change any of the framework, and I'm optimistic that it will continue because it has been so successful. And whilst funds will continue to reduce, the savings that you get from it, it's undisputable. Social care has benefited from it. GPs have benefited from it. So it's really just getting those partners who have been seeing the benefits to keep speaking up on behalf of the programme.
Well, and I guess from our kind of point of view, and a real value, if you like, of the social return on investment is it does combine that kind of quantitative and that qualitative. So you have kind of evidence of the impact, and you can kind of monetize that. So if you're talking to finance directors, that can be great, that can be really powerful. But you also have a lot of the evidence at an individual level in terms of kind of change, in terms of the kind of outcomes on loneliness and well-being, whatever that may be, that can actually support both service delivery for individuals and for the hubs, if you like, that are doing those assessments and those reviews. And then broadly for those services, you know, if there is still a group that actually they're still feeling as lonely, it should be evidence to help change, tweak that, you know, and also some of the human stories. And I think, you know, Angela's kind of provided loads of great photos, and you can see some of the videos as well. I think those human stories really help to bring it to life. And I think what we've tried to do that with the different types, that typology of clients, and with the different outcomes as well. So you have a combination, you have the kind of monetary value that really does speak, you know, really quite powerful. You have the other statistical data, but you also have those real people, those older people that were supported in Walsall and their stories. So it kind of combines all of those.
Great, thank you. That's very helpful.
We have a few more minutes. I don't know if anybody else has any final questions. Now's your opportunity to speak. Katie, go ahead.
Thank you. It was just about how you work out from the outset what types of scale and measure to use according to the duration of the contact that you're going to have, say, how to work that out. So for example, the work that I do, I have direct contact with what we call participants for approximately 3 months. And so we don't apply at the moment any of these. That's why I was asking about the PH2 and the Jong scales. We don't apply any kind of clinical measures scales like that at the moment, but we're thinking that we might need to in future, for the reasons that Angela's been, well, you've both been sort of talking through. I don't know, is there any kind of sort of way of working that out, what scales to use?
Do you want to go ahead, Angela? So you had a big
Yeah.
discussion about it.
So it's the approach I took wasn't a scientific one, really. It was a case of, okay, we've got older people. There are a whole range of services or ways in which we deliver public health intervention. So sometimes we may have 12-week intervention, 6-week intervention. We recognise that individuals would have a different need, but we wanted to have a beginning, an end, and it was felt actually we needed a middle so we can see the tracking of it. So there was the intervention, initial intervention, the review, a second review. We hope to have a second review, and then an end, and then a follow-up. A lot of it was ideal. So as much for some we was able to capture it, but for many it meant that maybe they had 2 reviews. Some didn't have 2 reviews, but they didn't need it necessarily. Some just needed connecting and leaving to it. So it was really a case of testing the waters. In terms of the loneliness, the campaign for loneliness had probably about 4 or 5 scales, potential scales that you could have chosen. And we found that this scale was probably best in terms of for the ability of the client to be able to use at the same time as the academic rigor. So that was why that one was particularly used. So the WHO5, the PHQ2, because it was a recognised measure for depression, we wanted to identify, are people struggling with depression initially, and then connect them to a more robust PHQ9 through the GPs. And we needed to use something that they recognised. So that's why that was chosen. The 5 Ways to Wellbeing approach, that really was the measure of how you put that individual through the journey. So I would like to, I'm not happy with the amount of social connection I have. So what are the barriers to social connection? And then we use that to track, how can we improve your social connectivity? And that became their wellbeing plans. So it was an approach rather than a measure. So it really is looking at where do you want to be in the end, and then reversing back, taking the back step. That's how we get there. That's how I chose the measures. So I wouldn't say it was scientific, but it was a process of, okay, here's the need, the end result. How do you get back? And also I worked with the data collection system. So there will be partners that you can link up with. And because we commissioned the data collection, they were able to say, actually, well, there's various tools out there you can use. What's the best tool for yourself? And this is what we're aware of is useful. So it was a multiplicity of activities and support mechanisms really to get to that decision.
And in terms of
Thanks.
In terms of SROI, there's Social Value UK is the kind of UK organisation that kind of oversees SROI, and it has a kind of library of SROI reports. So that's always a good kind of avenue to look at, just to compare, you know, what some of their findings are, but also what some of their tools, what some of their measures are for different type of activity, whether that's social prescribing, working with older people, working with younger people or children, environmental measures as well. So it's a useful source. So I will kind of call this to an end, I think. So lovely. Thanks everybody for coming today. It's been great to kind of share the work that Angela and colleagues have done in Walsall. Great to share some of the work that we've done in terms of the evaluation, SROI evaluation. We will follow this up with an email to all of you with the slides. We'll also link to the summary report as well, which is publicly available, and we'll have a little kind of survey there, just some kind of feedback to put. And also, if you have any other ideas, suggestions for any other webinars like this, particularly about different evaluation methods or different research projects that you'd like to hear about or speak about, do let us know there. So lovely. So thanks everybody for coming today. Okay.
Thank you very much, everyone. Bye-bye.